Hello, my name is Gani Fananapazir, and I will be sharing a presentation on imaging in kidney transplantation. We will divide this subject into 6 sections. These include normal anatomy, vascular complications, peritransplant collections, urinary issues, parenchymal abnormalities, and masses associated with kidney transplant. Let's start with anatomy. Kidney grafts can come from both living donors and deceased donors. Most kidney transplants are placed in the right iliac fossa in an extraperitoneal location. The arterial anastomosis is typically end to side, from the graft renal artery to the external iliac artery. The venous anastomosis is typically to the external iliac vein. The ureter is implanted into the dome of the bladder, creating a ureteroneocystostomy. When the external iliac artery is diseased, an alternative arterial anastomosis is an end-to-end anastomosis with the internal iliac artery. As pediatric deceased donors become smaller, arterial anastomosis with a graft artery becomes technically challenging. In these cases, both donor kidneys can be implanted en bloc. In this case, the larger donor aorta and inferior vena cava become anastomosed to the external iliac artery and vein, respectively. These are usually placed in the left iliac fossa. Knowledge of arterial anatomy is very important. The main renal artery gives way to segmental branches, and then to interlobar arteries, which run between the medullary pyramids. These arc around the medullary portions, forming arcuate arteries, which divide between the medullary portions and the cortex. Within the cortex, small perfusing end arteries are present, which are called interlobular arteries. Evaluation of perfusion of the transplanted kidney is very important. Ultrasound is our main imaging modality for kidney transplantation. Doppler, both color and power, allow assessment of perfusion, which should be seen extending to the cortex. A newer, non-Doppler technique called B-flow, or microvascular imaging, allows for greater spatial resolution, as can be seen here. The kidney parenchyma is depicted on this grayscale image. Here we can see that the medullary portions are usually slightly more hypoechoic than the cortex. Also note that there is physiologic, mild dilation of the collecting systems and ureter. This is normal and due to denervation of the graft, leading to decreased ureteral tone and also to reflux from the ureteroneocystostomy. Mild ectasia should not be mistakenly interpreted as hydronephrosis. Now moving on to the vascular section, which is the largest and, in my opinion, the most important topic of kidney transplantation. This is where the radiological interpretation is very much needed in transplant management. Arterial thrombosis is the most feared adverse outcome for kidney grafts. These usually occur within the first week of transplantation. Fortunately, these are usually not a diagnostic dilemma, as perfusional imaging will show a complete lack of flow within the kidney. Ultimately, these can only very rarely be treated, with the vast majority having irreversible damage. There can be situations in kidney transplantation where a kidney graft may have several renal arteries. only one of which may be thrombosed, or when there is thrombosis of a segmental branch. In this particular case, we can see flow only in the superior and mid portions of the kidney graft. Noting the location of the infarction and the size can help transplant surgeons and nephrologists determine outcomes. The inferior pole branches have classically been associated with blood supply to the ureter, and inferior pole thrombosis may need closer evaluation to ensure the patient does not necrose the graft ureter. Venous thrombosis also usually occurs within the first 1 or 2 weeks after transplantation. Venous thrombosis is the more challenging of the thromboses to diagnose. Patients often will maintain perfusion, though this can be reduced, as can be seen in this case. One of the hallmarks of venous thrombosis is reversal of flow within the arterial system, as seen here. On the color Doppler, we can see the red indicating forward flow in systole, with blue indicating the reversal of flow in diastole. Care should be made to not interpret blue within a vessel as representing venous flow, and spectral Doppler should be applied. In this case, we can see that the same vessel looks both red and blue, depending on the cardiac cycle. Not every case with a reversal of flow indicates venous thrombosis. In fact, severe acute tubular necrosis is the most common cause of reversal of flow. In cases of reversal of flow, the renal vein should be interrogated. In this particular case, no venous outflow from the kidney was seen on Doppler imaging. On the grayscale imaging, we can actually see the expansile clot within the renal vein. If caught early, the graft can potentially be salvaged, although this is uncommon. Transplant renal artery stenosis is the most common vascular complication, occurring in about 10% of cases. Most happen within the first 3 to 6 months. Clinical presentation is variable and includes hypertension, increased serum creatinine, generalized edema, and pulmonary edema. If unrecognized, prolonged ischemia can lead to fibrosis and poor graft survival. Initial evaluation is performed with ultrasound. The spectral Doppler appearance is critical to suggesting the diagnosis of transplant renal artery stenosis. Before a stenosis, flow within a vessel is laminar, which means that the highest velocity is in the middle of the vessel, with slower velocities as you get more peripheral. This is depicted on the spectral window by showing signal at each time point having a medium spectrum of velocities. When blood enters a stenosis, blood flows more rapidly and blood flows at the same rate. This is called plug flow. Therefore, the velocity will be elevated and the spectral range of velocities become narrowed. Distal to a stenosis, there is turbulence, which is manifested by a complete and total broadening of the spectral range of velocities. Another important clue of stenosis is the presence of parvus-tardus waveforms, more distal to a stenosis. At our institution, based on published research, we rely on the presence of 3 criteria to diagnose transplant renal artery stenosis. 1. A velocity greater than 300 centimeters per second. 2. The presence of spectral broadening within the transplanted renal artery. And 3. Parvus-tardus waveforms, defined as a time to peak of greater than 0.1 seconds. If none of these are present, there is essentially no chance of a stenosis. If any one of these are present, there is around a 30% chance, or an intermediate risk. If any 2 are present, there is an approximately 90% chance of a stenosis, indicating a high risk. And if all 3 are present, there is almost a 99% chance of a stenosis, rendering it a very high risk. In this classic example here, we see elevated velocity of greater than 800 centimeters per second, plug waveform. Distally, we see spectral broadening, as depicted here by complete opacification of the spectral window. And in the intraparenchymal arteries, distal to stenosis, we see parvus tardus waveforms. This would meet the criteria for very high risk of transplant renal artery stenosis. Here is the angiogram, which confirms the presence of transplant renal artery stenosis in the proximal portion of the graft renal artery. Now let's move on to another common vascular complication, arteriovenous fistulas. Almost all of these are iatrogenic, typically from biopsies, in which a biopsy needle creates a connection between the artery and vein, creating a low resistance circuit bypassing the end arterioles. Thus, a high velocity, low resistance circuit is created. This can be problematic if large and can lead to high output heart failure and decreased perfusion to the affected portion of the kidney. Most of these resolve spontaneously, but if large enough, they may require endovascular treatment. Here we can see a biopsy needle which was aimed too centrally towards the larger arteries and veins. After biopsy, an ultrasound was performed which demonstrates a flashing of Doppler signal, indicating turbulence from soft tissue vibration, also known as the sonographic bruit. This turbulence is not unique to arteriovenous fistulas and can be seen in any turbulent pathology, including transplant renal artery stenosis, arteriovenous fistulas, and pseudoaneurysms. However, spectral Doppler evaluation is diagnostic with its high velocity, low resistance waveform patterns as depicted here. In this particular example, the patient had two renal arteries. The spectral waveform on this renal artery was normal and supplied the non-affected portion of the kidney. Here is the spectral Doppler of the renal artery supplying the kidney that included the arteriovenous fistula, which demonstrates higher velocity and lower resistance waveforms. Pseudoaneurysms are a rare complication of kidney grafts. Here is a graphical depiction of an artery in the red arrow, in which there is disruption in the arterial wall with blood extravasating. Either the blood can coagulate or surrounding structures can enclose the leaking blood, which can either fully clot or, in the case of a pseudoaneurysm, non-clotted blood can flow in and out of the collection. In this depiction, red is used to depict the blood flowing towards the ultrasound transducer and blue away. This gives rise to the sonographic yin-yang sign. Here is a case of a cyst-appearing structure in a transplanted kidney. However, when Doppler is applied, you can see that it is a vascular structure with the classic yin-yang sign depicting this intraparenchymal pseudoaneurysm. Here is the same patient on B-flow, showing the swirling of blood within the pseudoaneurysm. It is not infrequent to have combined arteriovenous fistulas and pseudoaneurysms. In this case, we see an extrarenal cystic collection. However, on color Doppler, we see that this is actually an extrarenal pseudoaneurysm. Extrarenal pseudoaneurysms can be traumatic, can be due to an arterial anastomotic breakdown, or represent the sequelae of infection. These need to be managed emergently as opposed to intraparenchymal pseudoaneurysms, which are less urgent. Here is the angiographic depiction of the arterial venous fistula on the left, with a pseudoaneurysm on the right. So in summary, thrombosis is an early complication, typically in the first 2 weeks. Stenosis occurs later, typically within the first year. Sonographic features include elevated velocity, spectral broadening, and parvus tardus waveforms. Arterial venous fistulas are a post-biopsy complication. Their spectral waveform includes high velocity, low resistance. Pseudoaneurysms may be from biopsy, anastomotic breakdown, or infectious. Pseudoaneurysms can be intrarenal or extrarenal. The to and fro waveform on ultrasound is classic, and this is called the yin-yang sign. We now move on to a discussion of the various types of fluid collections, which include hematomas, urinomas, seromas, lymphoceles, and abscesses. Hematomas are probably the most common collection and can be seen in the immediate postoperative time frame or after a biopsy. Its location is important. They can be superficial, be lateral to the kidney, as is depicted here, involve the subcapsular region, or be medial to the kidney. Lateral collections, such as this one, are typically from venous oozing. The sonographic appearance of hematomas is variable based on its chronicity, but typically these are heterogeneous collections. On CT, these appear greater than simple fluid density, with Hounsfield units around 30. While there is concern about mass effect on the kidney, the greater clinical concern is actually its propensity to become infected. Here is an example of a subcapsular hematoma with mass effect on the kidney parenchyma, which is leading to the elevated resistive indices seen on the left. Here is an example of a medial collection. These require a level of concern, as their origin may be from the anastomotic region. In this particular case, the hypodense area centrally actually represented a pseudoaneurysm, which is confirmed on angiography, right here. Urinomas tend to be a simple fluid collection, typically noticed within the first 2 weeks of transplantation. However, they can also result from biopsy, as is seen in this case. In this particular case, the calyx was biopsied, leading to a urinary leak. However, more commonly, they occur because of ureteral necrosis. Here you can see the ultrasound on the top left, as well as the CT on the top right depicting the urinoma. On the bottom image is a nephrostogram, which shows the leakage of contrast into the collection, which now contains a pigtail catheter. Urinomas can be diagnosed on CT or MRI if they demonstrate contrast extravasation in the urinary phase by a nephrostogram, as is seen in this case, or it can also be diagnosed by aspirating its contents. Aspirated contents of urinoma will demonstrate fluid creatinines much greater than serum creatinines. However, given that these patients may have high serum creatinine levels to begin with, drawing simultaneously serum creatinines is important. Here's an example of a seroma. These represent seepage of plasma into the tissues. These will also typically appear as simple fluid collections. Lymphoceles represent surgical disruption of lymphatic channels and typically develop 4 to 8 weeks postoperatively, although these may occur even later than that. Most are asymptomatic, but they can develop mass effect, and depending on their location, they have been described to be associated with hydronephrosis. These, like urinomas and seromas, will appear as simple fluid. Any one of the above collections can become infected. Additionally, pyelonephritis can, if untreated, lead to abscess formation. These, like hematomas, can appear as complex collections. On CT, the presence of rim enhancement, as is seen here, and gas, as seen centrally, raise suspicion for abscess formation. So in summary, peritransplant collections can look similar. Lymphoceles, seromas, urinomas tend to look simple, whereas hematomas and abscesses can look complex. Acutely, urinomas, seromas, and hematomas should be considered. However, late presentation, one should think about a lymphocele. In order to be able to differentiate between them, typically you need to aspirate the fluid. Other thing to remember is that all of these fluid collections can become infected. In addition to urinomas, other urinary complications can occur. Ureteral stricture is the most common complication of the ureter. It typically occurs, like transplant renal artery stenosis, in the first few months and may represent scarring from rejection, ischemia, or technical error. The hydronephrosis, as seen here on the left, is much more pronounced than the physiologic hydronephrosis of a transplant kidney, and sometimes comparing with prior studies can be useful. Ureteral stones can also occur. They can either develop de novo within the transplanted kidney or can be imported from a deceased donor. In this particular case, the surgery team was unaware that the patient had a staghorn calculus, which was observed on the KUB performed to evaluate the ureteral stent. You can see the shadowing staghorn calculus on the ultrasound on the right. Ureteral stones can cause hydronephrosis if they become obstructed, as you can see in this case here. If one sees hydronephrosis on ultrasound, it is important to track the ureter as distally as possible. In this particular case, you can see a stone in the distal ureter at the ureteroneocystostomy site as the source of the obstruction. In summary for the urinary section, physiologic hydronephrosis in transplant kidneys is normal. However, when you see increasing hydronephrosis or marked hydronephrosis, this urinary obstruction can be caused by calculi, strictures, or rarely peritransplant collections. Parenchymal disorders include acute tubular necrosis, drug toxicity, rejection, and pyelonephritis. Most of these diagnoses are actually made off of biopsy or laboratory values rather than on imaging. However, there are some imaging features that can suggest different etiologies of parenchymal dysfunction. Acute tubular necrosis is caused by ischemic injury. In patients with transplanted kidneys from deceased donors, we know that they have a cold ischemic time during which there is decreased flow to the interlobular cortical perfusing arteries. This leads to ischemia, which leads to inflammation and swelling, which further increases ischemia. The tubules are prone to becoming ischemic and can eventually necrose, leading to the classic muddy brown casts in the urine. By imaging, cortical perfusion is low in acute cortical necrosis, as can be seen here. Mirroring that, the resistive index can be high, and even reverse in direction and diastole. However, as can be seen in this case, the renal vein is widely patent, effectively ruling out venous thrombosis. However, these findings are nonspecific and can be seen in a variety of settings, such as drug toxicity. Rejection is another disease process which can lead to a nonspecific imaging appearance. Although classically, patients with rejection have been described as having enlarged, hyperechoic kidneys with elevated resistive indices, more recent studies have suggested that these may not be useful in evaluating for rejection. The sign with the highest sensitivity for rejection appears to be the presence of urothelial thickening, as can be seen in this case of rejection. Pyelonephritis typically manifests as a wedge-shaped hypodense area on contrast-enhanced CT, as can be seen here. On ultrasound, the imaging features are much more subtle. In this case, the flagrant pyelonephritis on the left is much more subtle on ultrasound, where it can appear mildly hyperechoic with decreased flow on Doppler imaging. Pyelonephritis can lead to abscess formation, which sometimes can appear as an abscess with simple fluid or complex fluid echogenicity. However, pyelonephritis with an abscess can actually sometimes simulate a mass, as can be seen in this case. In summary, acute tubular necrosis, rejection, and drug toxicity can look similar to each other. Urothelial thickening is highly sensitive for rejection, but again is not specific. Ultimately, parenchymal disorders usually require a biopsy or laboratory values to be able to distinguish among them. Pyelonephritis is extremely limited by ultrasound. However, the complication of pyelonephritis of an abscess is useful to be evaluated by ultrasound. We will finally discuss masses. Post-transplant lymphoproliferative disorder is caused by Epstein-Barr virus-associated B lymphocyte proliferation. Lymphadenopathy is the most common imaging presentation, although masses involving the brain, liver, spleen, and bowel are also common. Involvement of the kidney itself is less common. In this case, we can see massive lymphadenopathy in the mesentery. Treatment is generally lowering the immunosuppressive medications, but also may involve antibody therapy or chemotherapy. Here is an example of splenic involvement of PTLD. And in this example here, we can see bowel wall thickening in a kidney transplant recipient, which was found to represent PTLD. Finally, any mass involving the native kidney can involve a transplanted kidney. In this case, the patient developed renal cell carcinoma within the transplanted kidney. So, in summary, PTLD can be seen as lymphadenopathy, bowel wall thickening, or visceral masses. And masses affecting the native kidneys can also affect the transplanted kidney. So that brings the talk to a conclusion. Thank you.